everyone. My name is Biosimilars and I'm the health educator for the Multiple Sclerosis Foundation. Before we start the webinar, I'd like to take a minute of your time and introduce this year's National MS Education and Awareness Month Toolkit right here. The theme for 2023 is MS in Today's World. If you are currently subscribed to our quarterly MS Focus magazine, then please be on the lookout to receive your 2023 toolkit in the next upcoming weeks. If you are not subscribed with us, please respond to your registration or reminder email of this webinar, and we can add you to our mailing list. This toolkit has different activities such as checklists and worksheets that can assist in keeping you grounded, but also finding new ways to prepare you for the upcoming future of MS. There are topics in here to guide you in your personal journey of living with MS, like advice featuring one of our speakers of this month's webinars, Dr. Pearl Warfel, healthcare tips as how to advocate for yourself, or the latest updates on FDA-approved treatments, and how to navigate within your MS community. To make this toolkit and today's webinar possible, I would like to personally thank our sponsors. Thank you for all of your time today and enjoy the webinar.
Good afternoon, and welcome to this National MS Education Awareness Month Conference hosted by MS Focus and Multiple Sclerosis Foundation and made possible with support from Biogen, Genentech, EMD Serrano, Sanofi, Viatris, Sandoz, and Bristol Myers Squibb. I'm your host, Chris Payne, editor for the MS Focus, and I'm joined today by Dr. Ben Thrower, who will be providing us with an update on MS treatments. After a presentation from Dr. Thrower, we'll throw it open for questions and comments. Now I'm delighted to introduce our speaker. Dr. Ben Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington, and Dr. Thrower is the Senior Medical Advisor for MS Focus, the Multiple Sclerosis Foundation. He enjoys contributing to our quarterly MS Focus magazine. We're pleased to have him join us to present on this important topic. Dr. Thrower, thank you for being with us, and I turn it over to you.
Great. Thank you very much. And as always, thank you to everyone at MS Focus for all of the wonderful work that you do, and thank you also to the sponsors who make all of this possible. So MS advances. Every year we learn new things, we get new treatment options. So I think it's a nice thing to start early in the year and say, well, what have we learned in the past year, and what might be on the very close horizon in terms of treatment options. And so I picked a few topics today to talk about. Generics and biosimilars may not seem like something very sexy and novel, but it's an important concept in MS. And I wanted to talk about some of the newer treatment options out there that fall into this category and help people understand a little bit what this means for the treatment landscape in multiple sclerosis. We're going to talk about a newly approved drug called Briambi or ublituximab. We're going to talk about a class of drugs that are just right around the corner called the BTK inhibitors, and then talk about two things that are not medications, that are devices that may help in dealing with MS. One is a device called the Helios Pons neural stimulator, and another device called the neural sleeve from a company called Psionics. So two of our medications, our oral medications, have gone off patent, meaning that there will be generic forms available. One just went off patent yesterday, teriflunomide or Aubagio. One went off patent a little bit ago, a few weeks ago, fingolimod or Gilenya. And I just thought it would be a nice thing to kind of step back and talk about kind of what it means to have generic medications. How does the FDA look at this issue, and what might it mean for how effective or safe a drug is? So By FDA rules, a generic drug has to have the same amount of the active ingredient of the name brand medication. So milligram per milligram, the active ingredient has to be exactly the same. Where there can be differences are with inactive ingredients, fillers, the capsule itself, colorings, additives, preservatives. So, if you were someone that has, sensitivities to certain things, this could be important to know in terms of what are the inactive ingredients in a generic drug. Just as importantly are allowances for minor differences in pharmacokinetic PK parameters compared to the name brand drug. So you could have the same milligrams of the active ingredient, but depending upon how that drug is absorbed to the system, you could have minor differences in these pharmacokinetic parameters. And the two that they most commonly look at are the peak plasma concentration, or the Cmax, and then something called area under the curve. Area under the curve is how much of the drug is in your system over how many hours. And what the FDA says is that a generic form of the name brand can have PK parameters that are from 80% to 125% of the name brand drug. So that peak plasma concentration could be 20% less than the name brand drug. It could be 25% more than the name brand drug. Where I think that comes into play clinically and could be of some importance is if you have a therapy with a very narrow therapeutic window. If you have a therapy, think back on some of our old seizure medicines like Dilantin. Dilantin had a very narrow therapeutic window, and if you change the blood level a little bit, you could go from having inadequate levels of the drug in your system to having side effects because you've got too much in your system. So that's a drug with a narrow therapeutic window. The other area where this becomes important is if your pharmacy is changing brands of generics on a regular basis. So let's say that there are 5 different versions of a generic drug of the name brand, and that maybe generic A is 80% of the peak plasma concentration, generic drug B is 125%, and your pharmacy switches those from time to time. That could be a big swing in how much of the drug is in your system. So other just generic drug facts, so they are generally cheaper than name brand versions. You'll never see a generic drug advertised on television. They don't go to healthcare providers and market these drugs. That's part of keeping the costs down. Pharmacies and insurance carriers technically don't have to ask for your permission or my permission to switch you from a name brand to a generic. They frequently will as a courtesy, but they don't have to. So you could, in theory, have been on a name brand version of the drug, and you show up at your pharmacy or you get your drug in the mail order, and it's now a generic version. Your healthcare provider, if they feel it's important, can specify name brand only on your prescriptions, so that no generics are substituted. So some other new things that are out there. These are not generics. These are what we call derivations of name brand drugs. So these are sort of a little different spin on something. So Tasenso ODT, or orally dissolving tablet, is fingolimod like Gilenya, but it's in a different form. So when you put it in your mouth, it just dissolves and is gone very quickly. So this is what we call a branded generic drug. So branded generic drugs are a little bit different in that the delivery system has been changed a little bit. The other new thing that we have in our toolbox is Bifiratam. So this is going to be a cousin of Tecfidera and Vumerity. So Tecfidera is dimethyl fumarate. Bifiratam is monomethyl fumarate. So very similar molecules. But again, it's not technically a generic version. Whereas Tecfidera has now gone off patent, and there are generic versions of dimethyl fumarate out there. Bifiratam is name brand only.
Dr. Thrower,
Yeah.
before you continue, do you mind sharing your slides?
Oh, so are they not up there?
No,
Oh
unfortunately.
my gosh. What happened to that?
Thank
Let's
you.
try this again.
Perfect. We can see them now.
Awesome.
Thank you.
Sorry about that.
No, thank you.
So let's catch up here. So we mentioned the term branded generic. So again, this is a little bit different from a regular generic. So a branded generic differs in some way from the original version, and it could be a different dosage. For instance, a pediatric dosage of the drug. It could have a different mechanism, just like we mentioned, the ODT, the orally dissolving tablet. These have both a trade name, like the Tasenso, and a molecular name. Your pharmacy or insurance carrier cannot switch you to a branded generic without your permission and the healthcare provider's permission. So I wanted to talk for just a second about some new options in the biologic world. So when we say biologic therapies, what do we mean? Biologics are medications that come from a living organism. And in our MS world, these would mainly be monoclonal antibodies. Things like Tysabri, Ocrevus, Kesimpta, Rituxan, Lemtrada, these are all monoclonal antibodies. So when the patent runs out on a biologic agent, we don't call that the competing brands a generic. We call them biosimilars, because these biologic drugs are complex. They're very difficult to copy identically. So when we talk about a quote unquote generic version of a biologic, we're going to use the term biosimilar. So they have, by FDA rules, they have to be shown to have the same efficacy or effectiveness and safety as the name brand, and pharmacies and insurance companies cannot automatically switch you. They have to get permission to do that. So why do I bring this up? So we have a big thing on the horizon. Tysabri, or natalizumab, has been one of our infusions that we use very commonly in managing MS, and it has been name brand only, but that patent is expiring, and there will be a biosimilar molecule to Tysabri. So the company that is manufacturing this biosimilar did a well-designed study called Antelope. It was a phase 3 study. And what they saw in the study is that the name brand Tysabri versus the biosimilar had very similar safety and efficacy. If that was the whole story, I think we would be potentially pretty comfortable in moving maybe between name brand Tysabri and this biosimilar. I think where life gets a little more complicated is with the JC virus antibody testing. If anyone listening is on Tysabri, you know that a big part of what lets us use Tysabri safely is JC virus antibody testing. Your JC virus antibody index determines your risk of PML, progressive multifocal leukoencephalopathy. That is the big bad side effect that we don't ever want to see with Tysabri. And this JC virus antibody testing is a lot of what lets us select appropriate individuals to be on Tysabri and let them stay on Tysabri safely by continuing to monitor that JC virus antibody index. That testing and all of the data that goes along with it is proprietary to the company that makes Tysabri, Biogen. And so this new company making their biosimilar, while the molecule they're making appears to be good, we don't know what the testing looks like. And so as we're speaking today, the last I've heard is that they will be developing their own testing method. And we just need to see what that looks like. We again, to use natalizumab, whether it's in the Tysabri form or in this biosimilar form, we've got to have access to regular reliable JC virus antibody testing. And so I think that we'll see where that all shakes out over the next few months here. So ublituximab, or Briambi, is brand new as of December 2022. Briambi, or ublituximab, is an anti-CD20 monoclonal antibody. It is similar very, very similar in terms of mechanism of action to Ocrevus, Kesimpta, Rituxan, Ruxolitinib, Truxima. These are all anti-CD20 monoclonal antibodies. I would say that ublituximab is probably a direct competitor for Ocrevus. They are both twice-a-year IV treatments. So what is the potential appeal to Briambi or ublituximab compared to Ocrevus? It is a faster infusion. So the full dose of Briambi or ublituximab can be given over 1 hour, and it is going to be priced about 15% cheaper than Ocrevus. So I think it's definitely going to be, you know, something welcome addition to our arsenal for managing multiple sclerosis. We'll see what insurance carriers end up doing with this. In a perfect world, we would love to have access to all of these medications. Frequently, insurance carriers, as many of you are probably aware, are going to sort of design their formularies, at least in part, based upon price. And it'll be interesting to see, do insurance carriers end up potentially preferring Briambi over Ocrevus? Or are there things going on behind the scenes? A lot of times there are, you know, discounts being given behind the scenes that may keep a drug on formulary. So we'll have to see, but it will be one more addition to our B cell therapy toolbox for managing MS. So along the lines of B cells, we do have this brand new class of drugs right around the corner, and these are called the BTK inhibitors. So BTK stands for Bruton tyrosine kinase. And what I have on the screen here, it's kind of a schematic of, so this is a B cell. And when we think about where drugs like Ocrevus, Rituxan, Kesimpta, Briambi now, where those drugs work here. They are monoclonal antibodies that bind to this CD20 receptor that is on the surface of B cells up to a point. That receptor actually goes away as B cells get more mature. But what this antibody does is it targets cells with that receptor for elimination. So the anti-CD20 monoclonal antibodies like Ocrevus and Briambi and Kesimpta are reducing the numbers of inflammatory B cells in your system. The BTK inhibitors are going to do things a little bit differently. So they are oral medications. So what the BTK inhibitor is going to do is it's going to be taken into the B cell. These molecules do have the ability to cross the blood-brain barrier, so they do get into the central nervous system. And what they do is they turn off the mechanism within the B cell to make more of itself. So they're stopping B cell replication within the cell itself. So far, the data that we're seeing shows that these appear to be very, very effective. So again, these are oral medications on a daily basis. Some of them are once daily, some twice daily. It is a small molecule that crosses the blood-brain barrier. Why is that important? Because it looks like these molecules may have another mechanism of action. They may be working within the brain and spinal cord on something called microglia and macrophages. Microglia and macrophages are present in both the central nervous system and in the periphery. Microglia are really present in the central nervous system only. And these are some of the immune cells that play a role in multiple sclerosis. So it may be that these BTK inhibitors are going to hit MS from two different angles, that they may hit the inflammatory component and they may stop some of the damage that's occurring within the central nervous system itself. Some of these molecules are being studied outside for progressive form of MS, which is always very, very interesting. I'm getting a message up here. Oops, my default Mac. Nope, never mind. So what are the BTK inhibitors that are out there? So there are, I would say, really three in contention. The one on the bottom, the fourth, looks like for financial reasons it may be sort of paused at this point. So whereas we've got, all of these different monoclonal antibodies in the MS world, all of these drugs are going to, instead of ending in MAB, these end in NIB. So evobrutinib is a drug that's being worked on through Merck and EMD Serono. I think that it probably is, in terms of timing, is the closest one. So its phase 3 study in relapsing forms of MS is fully enrolled, and we're getting readouts on the data at this point. I think we'll get a lot of information this summer. So I think that one is probably furthest down the line. We have tolebrutinib, which is a joint venture between Sanofi and Principia. So this one has several different studies going on out there. Some of the studies were paused due to liver function, LFT abnormalities. Some of the other studies are still ongoing. And then we have a Genentech product called fenebrutinib. This one is being looked at in primary progressive MS and relapsing forms of MS. The fourth one, again, I think looks like it's probably on pause. So InnoCare is a Chinese research group, drug manufacturer that then partnered with Biogen here in the US on a BTK inhibitor. But as of just recently, Biogen withdrew their support for that molecule. So I'm not sure quite where those studies are going to go. If maybe another company comes in and picks it up, but as of right now, the last one looks like it may be on hold. So exciting. We will wait and see, where these BTK inhibitors fit into the food chain. It would not be surprising if they have effectiveness that is up there with some of our most effective current therapies. And I think what would really be nice is if, they turn out to have some mechanisms that really bring something new to the table and show some effectiveness in progressive forms of MS. Progressive MS remains one of the toughest things for us to deal with in terms of really stopping that progression. We're pretty good at stopping active inflammation. We're pretty good at stopping new lesions on MRI and relapses. But what we really need to do is ultimately stop progression, and then hopefully in the future, have things that actually repair damage and reverse disability. So along the lines of maybe improving function right now, that I wanted to talk about two things. This one is an interesting device. It's from a company called Helios, and it is the Pons neural stimulator. So the holy grail of MS is to repair damage, repair myelin, repair nerve fibers, reduce the gliosis or scar tissue, and restore function in MS. And research is moving towards that goal. If we can't repair the damage, what if we could just reroute around it? So that speaks to the concept of neuroplasticity. So neuroplasticity is, again, being able to accommodate an injury and form new pathways around it. And that's what this device is hoping to do. So this is FDA approved as of late last year. Helios really did a lot of its initial work through the Department of Defense. They were doing studies in spinal cord injury and brain injury in veterans who had come back from Iraq or Afghanistan with injuries. And now they've branched out into multiple sclerosis. So what the device looks like, you can see the lady wearing it around her neck. It looks like it should be a set of headphones. And it has a little cord that comes off that you'll see in this picture. So this is the actual neural stimulator. So this is a little tab that is worn under the tongue while you're undergoing rehabilitation or you're doing vigorous exercise. So what we know from one study is that if we took a group of people with multiple sclerosis with walking issues, And we had that one group did do aggressive rehabilitation without wearing the device, and the other group did aggressive rehabilitation while wearing the device. The group that wore the device during rehabilitation had better walking outcomes. We are asking questions as to, does this only apply to walking? Does it apply to other things like upper extremity function or cognition or swallowing, vision? We just don't know. But so far the studies have focused on walking. The device itself is not it's not uncomfortable. It's not crazy expensive. I believe it's about $1,300. Of course, we'll have to wait and see how that shakes out with insurance coverage, but not unreasonably expensive. The challenging part of this program was really the rehabilitation piece. So we've just started our program. We have 3 individuals who have participated in this. We're going to get the data from those 3 individuals in the next couple of weeks. No issues with any side effects or tolerance. The amount of physical therapy is quite a bit. It is 3 times a week physical therapy for 12 weeks. Could some of this be done remotely, potentially through telerehab? We don't know. So right now it involves a lot of hands-on physical therapy. And the plan would be that then the individual is going to take this device home once they're finished with that 12 weeks of formal therapy, and they're going to use it in an exercise program at home, maybe touching bases with a physical therapist or a trainer via telerehab to make sure that they're keeping up with their goals. So very exciting stuff. And then this is the other device that I wanted to finish up with, and some of you may be familiar with this. We've talked about it a little bit. So this is another potential option for foot drop. Right now, when we think about managing foot drop, we have some simple over-the-counter devices, things like the Dorsey strap, which can be ordered without a prescription, the Sabo device, which is for foot drop, which can be ordered without a prescription. Then you get up into things that a physical therapist would prescribe, our traditional ankle foot orthotics and all the different sort of variations on that. And then we have the electrical or functional electrical stimulation devices, Walk Aid, Biosimilars, and now we've got a 3rd edition, this Psionics neural sleeve. The potential advantages to this over some of the previous electrical devices, it appears to hit more motor groups. I'll be honest, we've been trying to get our hands on one through the company so that we can trial it with patients, and we don't have one yet. It looks like it would be easier to put on than some of the other devices, but really with a lot of these devices, especially an expensive electrical device like Walk Aid, Biosimilars, and the Psionics device, it really takes getting the person into the physical therapy studio and trying them out. Before someone commits to the financial potential barriers to using one of these, we certainly want to make sure that it does what the person wants it to do. So I think with that, we will turn it over to the audience and see what thoughts, questions, clarifications. Again, I apologize that the slides weren't showing up early on, but they will be available if need be. So what questions have we got out there?
Well, first, give me just a second here. That's odd. Give me just a second. We do have some questions. Our first question is from D. Is the BTK taken in addition to Ocrevus or in place of Ocrevus?
This would be in place of Ocrevus. So this would be your only disease modifying therapy.
Our next question is from Mimi. What about if you experience fatigue on one leg instead of foot drop? I currently take dalfampridine.
So when we think about walking issues in MS, so you can have foot drop where really your ankle dorsiflexors and your hip flexors are really the primary muscles affected, Or you can have nerve fiber fatigue, where the whole leg is just weak, and the longer you go with an exercise or an activity, the weaker it gets. So you're just draining the battery electrically, and that's where dalfampridine comes in. One of the challenges with dalfampridine, the brand name is Ampera. The non-FDA approved version of dalfampridine is 4-aminopyridine. They all do the same thing. They work on that naked nerve fiber to try to improve your endurance. The challenge with those molecules is they just don't work for everybody, and we don't know why. On paper, we would think everybody with MS should get some benefit, maybe some more than others. But in reality, it's almost an all or none phenomenon, where about 40% of people respond and it can definitely tell a difference in their strength, and 60% of people really see almost nothing from it. I wish we understood. So let's imagine that you're someone that either you don't respond to dalfampridine, or you don't get as much benefit as you would like to get. What other things could we do? I think that's where some of the different rehab modalities, come into play. We do know that through strength training, resistance training, that people can sometimes improve their endurance a little bit. We've been involved in a couple of different studies that have looked at some more aggressive rehabilitation modalities. So one was with a study called downslope treadmill. So when we think about a treadmill, normally you think about walking on a level surface, or you crank it up so you're walking uphill. Well, what these researchers did is they said, well, what if we have people walk downhill? What would that look like in MS? There were two main findings. One is that people thought it was an easier exercise, and two was it seemed to equate to better endurance in real life. So that's one potential thing to think about. Some of when this study was done, most treadmills did not go down; they only went upper level. Some of the newer treadmills that are out there, including a lot of health club exercise facilities, gyms, do have that feature that you can set them downhill. And in this study, it was a 6-degree decline. It was you're walking down a 6-degree angle. In the study, we didn't have that, so they actually just took blocks and blocked the back of the treadmill up. If you ever try to do that at home, just make sure you're careful that you're doing something that the treadmill's not going to fall off of, and that you're not binding the belt that's going around. The other kind of more aggressive rehab modality that was looked at in research was something called FES bikes, functional electrical stimulation bikes. This is a traditional stationary bicycle. There's nothing fancy about the bike, but people had almost like a TENS unit hooked up to different muscles in their legs, and also the bike had the ability to propel itself if the person was fatiguing. So as the person was pedaling the bike and they started getting tired, this functional electrical stimulation machine is going to start firing their muscles for them. So if you can't get the signal from brain to muscle, the machine is going to take over. What this study also showed is that people who did this training program tended to have better endurance in the real world in terms of their leg strength.
All right, our next question comes from Karen. Karen, are you there?
Yes, I'm here. Thank you. Can you hear me?
Yes.
Yes.
Hi, Karen.
My question, Doctor, is the B cell obviously is the target for the BTK inhibitors and the CD20s. And one of them is just killing the B cells, and one of them is actually preventing them from duplicating. Correct?
Correct.
And my concern, what I've always thought about is I had been told that those are sort of the teenagers in the lifetime of the B cell. What sort of long-term ramifications are there for your whole immune system when you've lost an entire age group of B cells?
So we have memory B cells. And memory B cells, last a long, long time. So when you think about the anti-CD20 monoclonal antibodies, you are, because you're taking out that immature population of B cells, as you said, you're affecting your body's ability to form new immune memories. And that was very obvious to us during the COVID pandemic, especially the Delta surge. People on the anti-CD20 B cell therapies did not make an antibody response to COVID vaccination or to natural infection. They still made T cell responses because that class of drugs doesn't affect the T cells, but we definitely affected their antibody response. They couldn't form new memories. Vaccines that they'd had previously, maybe MMR, measles, mumps, rubella, they still had those memory B cells there, so they'd still mount an immune response to prior things, but new memories are a problem. We will need to see with these with the BTK inhibitors. So the BTK inhibitors, it's not just the proliferation, if you will, it's how B cells talk to each other and to other cells. So it's B cell signaling that they also seem to affect. What is that going to mean in terms of immunizations? I would think that it would not have the same effect that the anti-CD20s, but obviously we're going to see more studies on that to make sure that we're not compromising someone's immune system. That whole discussion really speaks to the balance that we need to find in MS. And we could, in theory, treat someone's MS with a high dose chemotherapy. We could just suppress your immune system and your MS would probably be pretty quiet, but you're going to get all the bad stuff that goes along with that. You're going to get infections and maybe secondary cancer risk from being immunocompromised. So we always want to find that right balance between you just hitting the part of the immune system that's overactive, leaving everything else alone, and being mindful that, there are bad bugs out there. I think we're hopefully on the good side of COVID at this point, but who knows? Does something else pop up down the line that people need their immune system for? Good question, though.
Thank you, Karen. I want to take this opportunity to remind everybody that if you have a question or comment, you can ask it using the Q&A button in the app, which also allows you to send your question anonymously if you choose, or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you and then you will be able to unmute and ask your question. Our next question comes from Mary. She asks, is there any information available on the risk profile associated with BTK inhibitors?
So if you go on the National MS Society's website, there is some information there. You can always pull up what studies have been published to date. Depending upon how deeply into a subject you want to get, if people are not aware of the website PubMed, 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 that is the database for any peer-reviewed scientific article in the history of humanity. So you could go on that website, type in BTK inhibitors and multiple sclerosis. You will want to specify multiple sclerosis because this class of drugs got its start originally in managing certain blood-borne cancers, things like lymphomas and leukemias. The dosing and the risk tolerance in that patient population is going to be very different than in MS. So there are other BTK inhibitors that have been used in certain cancers that probably would never see the light of day in MS because maybe the risk is too high. So if you start searching for information on BTK inhibitors, make sure you kind of specify that you want MS information. So National MS Society, the PubMed, if you really want to pull up the articles themselves, as these things start coming online, we will put things in the MS Focus magazine as studies are published, kind of bringing people up to date too, and summarizing both the safety and effectiveness of these new agents.
Our next question comes from Louis. Louis, are you there? Louis, can you hear us?
Can you hear me now?
Yes.
Gotcha.
All right. Thank you. All right. I recently just took a treatment called Limtrada, and I wanted to know what you think about Limtrada.
So Lemtrada, for people that are not familiar with it, is alemtuzumab. So it's one of our MAB drugs, monoclonal antibodies. So specifically, it's an anti-CD52 monoclonal antibody. So these CD52 receptors are present on both B and T cells. So Lemtrada can be a very, very effective drug. It is hitting a broader repertoire of cells. We think what's happening with Lemtrada is you're knocking down inflammatory B and T cells, and then you're letting them come back. It's almost like you're rebooting the computer. So you're letting them come back in a state that doesn't want to attack your myelin and your axons. I would say the risk with Lemtrada is something that people need to be aware of. It is a very effective drug, but there's a certain amount of screening that needs to be done before people take it. And you're very familiar with that, Louis, of the blood testing, and there's blood testing that will need to be done, periodically after your
Yeah, they do it every month.
yeah. And so I think as long as people are staying up on those things, the other potential risk with Lemtrada is that, when the B cells repopulate after you knock them down, occasionally they come back in a temporarily slightly more angry state, not MS angry, other autoimmune disease angry. So you can see things like autoimmune thyroid problems like Graves' disease that have come up. Some kidney issues have been reported. But centers that are using Lemtrada, just like Tysabri and some of our other drugs, have usually had extensive training by the doctors, the nurses, to know what to look for with all of those things. And they want to make sure that someone like yourself is very well aware of, what the positives and negatives are of Lemtrada. I mean, it doesn't get much more convenient. I mean, basically, you've got 2 courses and you're done for life.
Right. And that's why I decided I'm young and I can bounce back, and I have. So I'm still, bouncing back. I got in January, late January, on my birthday this year, put my health first and my second dose, and I'm hoping for the best.
Awesome. Well, good luck to you.
Thank you,
Thank
Louis.
you.
Our next question comes from Janice. Do any of the present available medications or BTKs have any effect on secondary progressive or primary progressive MS?
So putting the BTK inhibitors aside for just a second, if we're really just being hard-nosed, the only drug that is approved for a purely progressive form of MS is Ocrevus for primary progressive MS. When we shift over to secondary progressive, folks may be aware that the way we categorize secondary progressive MS has changed a little bit. They've divided it into secondary progressive MS with activity and secondary progressive MS without activity. When we say with activity, we mean that the person is either having an occasional relapse or they're having new or enlarging lesions on MRI, or both of those things. Without activity, it's just pure progression, what most people would think of as classic secondary progressive MS. So no relapses, no new lesions on MRI. So we use this broad term, relapsing forms of MS. And what you're seeing now is that a lot of drugs, when they get FDA approval for MS, they are FDA approved for relapsing forms of MS. That would include people who've only had one attack or a clinically isolated syndrome, but have risk factors that would make us think that they're at high risk to having another attack. So clinically isolated syndrome, traditional relapsing remitting MS, and secondary progressive MS with activity. So those are technically your relapsing forms of MS. The BTK inhibitors, I know that one of them is in testing for primary progressive MS. Let me just flip back here to the slides for a second. To my knowledge, I don't know of a secondary progressive, but the second one on here, the tolobrutinib, that's the one where there are a lot of different studies going on. There may be a pure secondary progressive MS study, buried in there. And, one thing I want to make sure that, that people in the MS community understand is that on the healthcare end of things, we get it that it's very frustrating that a lot of the talk and the research, for decades seems to focus on relapsing forms of MS. It is not for lack of interest in progressive forms of MS. Progressive MS is more difficult. Most of our therapies that we think of in MS are anti-inflammatory, and inflammation is not as big a part. It's not that it's not a part, it's just not as big of a part in purely progressive forms of MS. So your target is just a lot smaller. There have been just major research efforts and think tanks and focus groups in the research world that are focusing on MS progression with no new MRI lesions, with no relapses. That just drives everyone crazy. And so I want to make sure the MS community hears that we hear you, and we know it's an issue. And I'm very hopeful that it's an issue that we're going to have an answer to in the near future.
I'd like to take this moment to remind everyone that if you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send your question anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you will be able to unmute and ask your question. And for our next question, we have Tammy. Tammy, can you hear us?
I can hear you. Can you hear me?
We can.
Yeah, we can.
Okay. I had a question. I mean, I have had MS since 1988. And my biggest complaint is the vertigo that I get from it due to the lesion on my central brain. And nobody seems to understand how to make that dizziness go away. I didn't know if you had any.
Yeah, vertigo is one of those really obnoxious symptoms that you just cannot ignore it. If you suffer vertigo, it is all encompassing, and you're just not going to be very functional while that's acting up. We think about symptomatically managing vertigo. We're not thrilled with the medications that we have. So, Antivert or meclizine and scopolamine patches are the things that are sometimes used most commonly, and typically for vertigo from MS, they're not going to be that effective. If someone is having a really bad attack of vertigo, just miserable, we can use the benzodiazepines. These are your Valium, Ativan type drugs, just to make someone comfortable. Not our favorite thing to do, because you're going to be comfortable, but you're going to be really sleepy also. And so it's not like you're going to have a very functional day that day.
Right.
We use a lot of vestibular rehabilitation specialists. So there are physical, and I'm not sure if you've worked with one.
Yes, I've been to 2 of them.
I think we tend to see more bang for the buck from that. And then neuro-otologists sometimes work side by side. So these are neurologists who've done specialized training in vertigo, or it could be an ear, nose, and throat person who's done specialized training in more neuro type stuff. There are some fancier machines. I don't know if they've tortured you with, there's something called the Bergtron balance machine. It looks
yes.
Have you been in the Bergtron?
Yes.
If all of those things are not working out, you want to certainly keep your eye on the horizon with research. I mean, ultimately, if we could repair the damage with that, with what we would assume is a brainstem lesion, that would be the ultimate answer to get rid of your vertigo and quiet things down. I think thinking outside the box, even if I'm suffering from vertigo, I'm going to try everything I can to treat that. I would probably look at even things like THC, cannabis, to see there. You have to be careful, and probably if you've not tried it, you have to probably start with very, very low doses, because sometimes one of the side effects if you get too much THC is dizziness and vertigo. So you would want to be really gentle, I think, with that, probably an edible THC, and just ease your way into it to see if it has any effect on the vertigo for you. One of the things we know THC does is it's really good for nausea. So even if it didn't necessarily shut all of the vertigo down, it might be a big help with the nausea from the vertigo.
Right. Yeah, because my neurologist has me on clonazepam.
So that's
And
that benzodiazepine family, like the Valium and Ativan.
right, but it's still not enough to get it out.
I would maybe take a look at some of what state do you live in?
Massachusetts.
So you're in a state where cannabis is legal.
Yes.
And I don't know how that works, if you want to do it medically or just go out to dispensary and try something. But if you were going to do a THC gummy, I would probably start with like a 5 milligram, and try that at a time when you're not going to be out driving. You can be at home to see what response you get with it. Where people get in trouble sometimes with cannabinoids in edible form is they'll take something like a 5 milligram and they don't feel anything after an hour, and they take another one, and then they've got too much on board. So
Right.
when you're trying to figure out your dosing, maybe take 5 milligrams one day. If that doesn't do it, wait until the next day. Then try maybe 7.5 milligrams. If that doesn't do it, wait till the next day. Then try 10. If 10 doesn't make even a dent in it, I'm not sure that's going to be the path to go down.
Right. Yeah, because I've tried CBD, which doesn't have any THC in it. And I got so stoned.
Really? So you may be very, very sensitive, because most people can tolerate CBD without any high effects. So yeah, I'd just be if you're going to try the THC, be very gentle and slow with it.
Yeah. Now, do you think that the vertigo could have something to do with nodules on my thyroid?
Not typically.
No.
So with vertigo, true honest to God vertigo, where you feel you're spinning, or there are really only 3 things in the human body that can generate vertigo. It's either in your inner ear, the nerve from the inner ear to the brainstem, or the brainstem itself. That's really it. And so with MS, we assume that it's the brainstem from demyelination.
Right. All right. Well, my next step, I'm going to end up going to see a chiropractor, I think, to see if he can.
My thinking would be like yours. I would probably try just about anything where the risk is not significant because vertigo is no fun. Well, good luck to you. I hope you get some relief.
All right. Our next question comes from Aaron. Who is the ideal patient for BTK inhibitors?
So that's a good question, and I will say it depends upon probably the school of thought that your neurologist is living in. So a lot of MS centers and a lot of healthcare providers that work almost exclusively with MS, we live in the let's be as aggressive as humanly possible within the bounds of safety camp. And so if the BTK inhibitors are going to be a very effective class of drugs, we would probably think of them as something that would be used very early on in people with relapsing forms of MS. If they are shown to be effective in progressive forms of MS, well, that's wonderful. We would probably use them as our first line option in progressive forms of MS if they look good there. So what we don't know at this point is what are insurance companies going to do with it? Are they going to require something called step edits? Step edits drive us crazy. So step edit is saying, I know your doctor wants to use drug C, but we as an insurance carrier are going to make you try drug A and B before you get to C. And a lot of times the A and B may make no medical sense whatsoever. So again, assuming that the BTK inhibitors look really effective and that their safety profile is reasonable, I think most MS healthcare providers would think about using them fairly early on. Right now, when we think about very effective therapies, we think of things, like the Tysabri and the B cell, the anti-CD20 monoclonal antibodies, and Mavenclad, the oral medication, as being kind of super effective drugs. And then right underneath that would probably be the S1P modulators, your things like Gilenya and Zeposia and Mayzent.
All right, our last question comes from Mayzil. Did I pronounce your name right?
Yes,
Hooray.
Marcial,
I was afraid I'd mangle it.
Marcial is Spanish. So yeah, so I wanted to know how effective is Xtavia in relapsing remitting MS?
So, Xtavia is beta-seron, is interferon beta 1b. That was our very first, FDA approved medication, and it can be very effective. So one of the points, as we think about new therapies that are coming out is, if you're doing fine on your existing therapy, there's nothing to say that you have to move to a new therapy. We think about beta-seron or Xtavia. That drug's been around since 1993. I have people who've been on that drug since 1993, and they don't mind doing the shots, and their MS is stable. Our goal for MS treatment is an acronym called NEDA, N-E-D-A, no evidence of disease activity, no relapse, no progression of disability, no new MRI lesions, and you tolerate it, you're happy with it. If you're getting all those things, you're getting an A on your MS exam, and there's nothing to say that you absolutely have to switch to anything else. If you're not getting all of those things, if you have had a relapse, or you've got new lesions on MRI, or you're seeing progression of disability, that's when the discussion needs to occur. Okay, can we do better? Do we need to think about moving to something else? But yeah, nothing wrong with Xtavia.
So then how quickly is it going to fix balance?
How quickly is it going to fix balance?
Yeah, I see my balance pick up with Xtavia.
Yeah.
I'm still shooting for more.
So remember what we just said about NEDA, N-E-D-A. What's the goal of any of these disease modifying therapies? I don't care if it's Ocrevus, Xtavia, Tysabri, Briambi. The goal is to keep you the same. So no progression. Think of these drugs like an insurance policy for the future. They're just going to keep you from getting any worse. They're not designed to make you feel better. And I know it's a weird concept, because normally when we take a medicine, something gets better. Our headache gets better. Our blood sugar gets better. Our blood pressure gets better. These drugs really aren't designed to do that. There are lucky individuals across all these medications who do see improvement with the medication. That's great. That's icing on the cake when that happens. But really, if you're staying the same on the medication, that is a success. If we can keep your MS right where it's at and let technology catch up to you and give you a repair option down the line, that's really what we're trying to do. So don't think of your Xtavia as something that should make any symptom better. If your balance needs to be worked on, you need to work with a physical therapist to do that, or talk to your treatment team about how can I improve my balance, because it really isn't the Xtavia that's going to do that necessarily.
I've seen improvements, thank God. I've seen improvements, thank God. But I have a question. Maybe you can't even answer, because I don't know if you would know right now. But with PML, there's no treat. I mean, there's ways to treat it, but there's no big treatment that will take it away right now.
No,
right?
so PML is the way that we really want to think about PML is you want to prevent it. There is, you said it correctly, there is no treatment for PML. You want to, if someone develops PML on a certain MS drug, you want to get them off of that drug and let their immune system try to fight it off. But really what we want to do is spend a lot of time up front selecting appropriate people for whatever therapy might have some risk of PML. So like with your Xtavia, there's zero risk of PML with that drug, so nothing to worry about there. Whereas when we think about something like a Tysabri or some of the S1P oral medicines like a fingolimod, there is risk of PML. So you want to think about selecting the right person for that medication and then doing regular JC virus antibody testing to make sure that their good safe numbers aren't changing into maybe a less desirable JC virus number.
I have PML. Tysabri gave it to me. I was in Tysabri since I was 18
Wow.
years old. Yeah. So
So
it
you're-
was heaven sent at that time. I
So
got
you're-
through high school and college.
Wow, you have special angels watching over you.
Yeah. So then after that, then it came back to bite me, and I got PML.
Wow.
So
Well,
that's
I'm
what
glad you recovered. That is wonderful news.
I had to do surgery on my eyes.
Yeah.
To try to keep them from drooping.
So obviously, you would never want to be back on any medication where there's really any significant PML risk. And so
No.
Xtavia, zero PML risk with that drug.
Thank God.
Yeah. Well, I'm glad you
I'm afraid
recovered.
that's all we
Yep.
have time for. That brings us to the end of our time. If you missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access recordings or sign up for our newsletter to learn about upcoming events. Be with us next time when our teleconference will be at 3 p.m. March 16th, when Sherry Binns will discuss making yourself heard by your healthcare team. Once again, we'd like to thank Biogen, Genentech, EMD Serrano, Sanofi, Viatris, Sandoz, and Bristol Myers Squibb for their support of this program. Our sincere thanks to all of our attendees for your participation, and especially for Dr. Ben Thrower. Thank you so much for the time you spent to prepare and share this information with us. We greatly appreciate each of you filling out our post-event survey, which will be available as soon as you leave this conference. Your participation in the survey will help us greatly in creating meaningful programming for the MS community. Goodbye, everyone, and we look forward to seeing you again next time.